Welcome to the Ikigai webinar series. Thanks, Kat. This,
Evening.
this is definitely like the most popular webinar, isn't it, this year?
Well, I was just thinking to myself that I wonder who hasn't seen it.
Thing is, there's always something new.
Yeah,
And I know if it's for me, I like things live,
yeah,
because if it's on demand, I tend to kind of file it and say I'll watch it and I don't. It's a
yeah.
bit like screenshotting, you
I
never really go back. So I think it's just nice that it's live. And
know.
it's a topic that you need to keep going over and recapping and making sure you have the latest evidence, don't you? So
And the crazy thing is that even now I do get questions all the time about air polishing, about powder therapy, about what powder, about when I should use it. So actually I joke about who could possibly not know after I've done this webinar. How many times have we done this now? I've lost count.
no.
Um, but the fact is that it's still really, one of those topics that people don't really know an awful lot about and are interested and patients love it. So
Absolutely. And the thing is, we don't have S3 guidelines yet. So I think that's as well why people are keen to keep on what's the latest evidence, what's going on. So welcome, everybody. And just while we are waiting, I just want to share a little slide deck with you. Can you see that, Kat?
it's up.
Yep. So next week we are running a Pecha Kucha event. And if you don't know what that is, think of it like it's a mini webinar. And the presenters have 20 slides and then they only have 20 seconds per slide. So the whole presentation takes 6 minutes, 38 seconds. So we have 6 speakers next Thursday with really exciting topics. It's going to be a little bit of fun. We also have a judging panel. Isn't coming up for me, but I'm going to post on social media about it. And next Thursday, 7:30, we've got Chris Barrow, Drew Shah, Alex Brackenhoff, Elaine Tilling, Jenny Walker, who have I missed? Mike Bentley. And they're all the judges. And then we've got the 6 presenters. We'll have a little bit of fun. And one other thing that we've decided that we're going to do is that we're going to put in a little request area. So you can send in if you'd like to say thank you to somebody that's helped or supported you this year. And we'll call it out on the webinar that evening.
That's so nice, Siobhan. That's such a lovely idea.
Yeah, so you can just send it to info@siobhankelleher.com or to Kat or to me on social media, and we'll make sure that we air it. So if you'd like to just say it out loud to thank somebody, let us know. So getting back to this evening, all about air polish, and I'm going to hand it over to the lovely Kat. Kat is a dental therapist. She has lots of qualifications, which I'm sure you have in a slide there, Kat, and you'll tell the audience more about it, and I'll hand it straight over to you. Thank you very much.
Thank you so much. I need to update this slide. I've just realized after you've said that. I normally skip past it as quickly as I possibly can. Evening, everybody. My name's Kat. I'm a dental therapist and the founder of The Modern Therapist. And I'm so delighted to be here. I'm on my husband's swivelly office chair, so I'm sorry if I'm making everyone dizzy by moving. Delighted to be here this evening to talk all about air polish and to talk to you about how we use air polish with our patients. So without further ado, the aims and objectives for the evening are that we want to heighten the awareness of the use of air polishing or powder therapy in practice, to be able to recognize what air polishing powder you are using and when you should use it. And also to think about or to consider how to promote air polishing with your patients, but also with your colleagues. So we're going to make sure that the Q&A is open. So if anyone has any questions or wants to put any questions in the chat, please feel free to throughout, and we are more than happy to help you answer your questions. And yeah, we are going to get into all about air polishing. Well, where did air polishing start? Well, it actually is not a new concept at all. In fact, it was developed as a form of dental technology by the infamous Dr. Robert Black as far back as 1945. He actually created an air polishing machine, or a powder therapy machine, that would cut enamel. And his idea was to create a way of treating dental caries, to cut enamel around dental caries using something other than a rotary drill. Now, obviously, it didn't work out well for him in terms of cutting cavities. But we have now had it refined, had the processes refined, the materials refined, the products have been really tested and developed to be much more precise. And it's finally now, finally was marketed in the mid-1970s by Dentsply as a stain removal treatment. And originally at that point, it was only for use on supragingival surfaces, but there have been a multitude of new powders and new technologies that are on the market. And so now it's become far more mainstream, and it's definitely a treatment modality that a lot of patients are even asking us for, not the other way around, not us telling them what they should have. So, what is air polish? Well, it is a jet of air, powder, and water. I love this slow-mo video. This is actually a very well-known endodontist having his teeth cleaned. I just remember it so well, saying, right, we need a slow-mo of this amazing stain removal. The air, powder, and water, they combine outside of the nozzle of the air polishing machine to effectively remove stains, biofilm as well, and in immature calculus, if you're lucky enough to get to it early enough. As I say, there are many products and many powders on the market, and so we really need to learn all about air polish. We need to have knowledge to be able to use it correctly, and to choose the right powders, the right equipment for the right indications. So, very simply, why do we air polish? Well, it's comfortable, it's quick, and it's effective. And it's not just comfortable, quick, and effective for our patients, but also for us as clinicians. So it's a win-win situation. My very first time using an air polishing device was, gosh, way back in 2000, it must have been 2008. And I remember I had very little training, just a quick whiz through with one of the dentists in the practice, who probably, I don't think, even knew how to use it themselves. Little bit of training, and the thing was just powder everywhere, absolute carnage. It was a mess, and then very promptly it blocked up, and I didn't really use it again. I found that my room would be covered in powder, and it would be really tricky to use. But oh my goodness, things have come on since then so much. We're talking, it's been 16 years since then, and we have this amazing array of products on the market that do make it quick and effective. We don't have to deal with loads of mess and powder all over our rooms anymore. And then what is it that we're tackling? What is the point of all of this? Well, obviously, the initial thing is to manage biofilm. So biofilm management is key. Obviously, we want to not only disturb the biofilm for our patients, but we want to educate them on it. Biofilm is a complex of communities of disease-causing bacteria. So it's this sticky plaque that we see building up on oral surfaces, including gums, restorations, prosthesis, and 70% of biofilm is live organisms, okay, in comparison to calculus, which obviously we like to remove as well, and we talk about calculus a lot in our ultrasonic tip selection webinar, but really biofilm is the live organism, is the live issue that is causing inflammation for our patients and causing decay and periodontal diseases for our patients. And in addition to that, we are tackling staining. And although staining is primarily seen as a cosmetic concern, we all know that where there's stain, there's biofilm, because stain is rough. And so it is a wonderful place for our biofilm disease-causing communities to adhere to the tooth, because the stain has allowed it to be able to do that. So a couple of examples of the type of staining we might be coming across: some chlorhexidine. I always joke with my patients that their Corsadil mouthwash keeps me in business. Corsadil certainly stains a lot. Actually, we've moved over to Curaprox mouthwash at our clinic now because it doesn't stain. Smoking stains. If you are unlucky enough to have a huge cohort of patients that smoke, then you will recognize this staining instantly. It's tar-like black sticky stain. Then there's my personal favorite. Is it possible to have a favorite when it comes to stains? I don't know, but I love to recognize chromogenic staining on my patients. We had a lady this morning, and it was so funny because my nurse Gintari was scolding me for not taking before and after pictures. Actually, I should have made her do the slow-mo video on that one. It was brilliant, and we were both exclaiming how much fun we were having air polishing off the chromogenic bacteria staining. So chromogenic staining is these black pigmented bacteria, and it's really recognizable by this sort of pitted black dotty effect that you get mainly around gingival margins of teeth, and I see it on women for a lot more than men, weirdly. Other types of staining you might be noticing that we can tackle with air polishing is dietary staining. So, you know, your teas, coffees, poor oral hygiene. So in this case, in the middle, you can see why that stain's there, because those teeth are overlapping and the patient isn't managing to get their toothbrush into that really tricky area at the incisal edge of the upper right one. And then we do also see staining caused by supplements. So quite often, if you have a patient who they take iron supplements, or even those patients that chew gummies, the vitamin gummies, I find that they have a lot of stains on them as well. So if you've got patients that don't know why they're stained, then that is a wonderful list to go through. Could it be this? Could it be that? Black tea, black coffee, red wine, you know, all of those things, all those wonderful things that keep us in business in our hygiene diaries. And then what is out there? Well, as I said, I started way back when with a quite old-fashioned version of the Cavo Profiflex, which is the one you can see on the bottom there of the page. And that's the one with the really skinny, long, thin nozzle and the heavy back chamber. So that's the one I started with. But there are loads of these little air polishing devices that will attach to the fast handpiece on your chair. It wants to be on the fast handpiece coupling on your chair because you need the air and the water. And then obviously in the center there, we've got the NSK Profimate Neo, and to the left of it, we've got the NSK Perio Mate. So those two are a pair. They are to be used with two different powders, which we'll go into later on. And then, you know, you may have your EMS products, you may have your Action Air and Go product, and Cavitron Jet also has their own standalone machine. So I would say that these are sort of your entry-level type air polishing devices. This is certainly where I started with air polishing, was you know, like, as I say, with the Cavo Profiflex, and then I moved quite quickly onto having my NSK Profimate Neo. I was really fortunate that NSK actually loaned my practice a Profimate Neo and a Perio Mate for 2 weeks. I got a 2-week loan, and in those 2 weeks I basically converted my whole practice to loving air polish, and my patients as well, and we actually made enough income to pay for them. So within 2 weeks I bought them, thanks to the loan from NSK, which was wonderful. And now over the years I've upgraded, and I've been super fortunate for the last 4 years, maybe 5 now actually, last 5 years, to be using the NSK Various Combi Pro, which is this standalone machine which has both piezo technology on the right, and it's got the air polish technology on the left, and you can switch between super and subgingival on that machine. Other standalone machines that you might have heard of what might be the EMS Master, the AquaCut machine. There are a few new ones on the market. BA International have just brought out their machine, and this, you can see this Mectron machine as well. So some of them are just air polish, some of them are air polish and P-Zone combined. The AquaCut is only air polish, but in addition, you can use that to prep teeth as well. So it's got different powder capabilities, whereas the other 4 machines are for perio prophylaxis only. So really depends on what you've got in your surgeries, what you can persuade your dentists to get you, or your clinic owners to get you in your surgeries. And then to add to confusion, so first we've got the handheld machines, then we've got the standalone machines. To add to the confusion, we've also got tons of different products when it comes to powder therapy. So what powder are you using to go into these machines is of key importance as well. And so today I really want to take you through this huge array of products and types of powders, sizes of powders, indications of powders, so that you feel super confident in what machine you've got and what powders you use and for what patient. So what powder when is probably our biggest question. So the first thing to note is it's really important to know what machine you're using before you choose what powder you're using. Firstly, the machine's shape and size will have been developed for a specific powder shape and size as well. And so you must always try to contact the manufacturer of your machine. Those that are looking after you when the machine needs servicing, they're the people that are going to tell you exactly how to look after it and what powders to use in it. Essentially, particle shape and size and the abrasivity of the powder that you choose plays a massive choice in what one you're going to use and when and how you're going to use it. Okay, so there are lots of different types of abrasive powders used in air polishing, and they all have different indications. They all do different things to the teeth and to the restoration and the prosthesis that we find in our patients' mouths. Okay, so there's lots of studies around powders. One of the main things that we need to understand is how hard are they? So we can make powder out of a multitude of different things, but how hard are they? And the Mons scale of mineral hardness is this qualitative ordinal scale ranging from 1 to 10, which characterizes scratch resistance of various materials or minerals. So what that means is it's telling us how hard is a material in comparison to other materials, with talc being the softest at 1 and diamonds being the hardest at 10. Okay, so on that scale you would expect dentine to be around about a 2. Okay, so dentine is generally around about a 2 on the hardness scale. So when it comes to powders that we choose, we really want to choose powders that won't damage the tissues that we are using those powders on. Okay, so with dentine being around about a 2, we want to choose powders that are, if we're using them on dentine, that are not going to damage them. The first powder that was ever really produced commercially for air polishing is sodium bicarbonate. And if there's any chemists out there amongst you in the audience, you will know that this is a salt. But sodium bicarbonate is the most common powder that's been developed for air polishing. There's many different brands that use sodium bicarbonate. One of your most notable or biggest brands that you might be aware of is EMS. Their Airflow Classic powder is made from sodium bicarbonate. And across the brands, the average general size is 74 microns. Now, 74 microns doesn't sound huge, but in the air polishing world, it's actually quite a large particle size. And it's also, because of it being a salt, it's quite an uneven particle shape. Now, obviously, again, the salt issue is going to be a problem for anyone who's on a sodium restricted diet. So if you've got patients who've been told they have to restrict their salt intake, maybe because of their heart health, or whatever medical condition it is that they might be suffering from, then we cannot use sodium bicarbonate. It has been shown, because of the particle size and because it is a little bit harder on the hardness scale, then it has been shown to cause damage to cementum, to dentine, and to restorative materials. So restorative materials such as your composites, your metal restorations, your luting cements, it can actually damage those in the mouth visibly, so you can see the change. And so for that reason, sodium bicarbonate is indicated only for supragingival use and only for patients who obviously do not have sodium restricted diets. And as with majority of air polishing machines, it's contraindicated on patients with asthmatic or bronchial conditions, so with any lung conditions. So that's your sodium bicarbonate. Because they had sodium bicarbonate developed in the 70s, and there was this concern around patients not being able to have sodium, they then developed aluminium trihydroxide. I almost went for the American aluminum then. I don't know why I did that. Aluminium trihydroxide was developed as this initial alternative to sodium bicarbonate. But the problem with aluminium trihydroxide is it's difficult to control particle sizes. So the size varies from 80 right the way up to 325 microns, which is a huge particle size. And it's also much harder on that Mohs hardness scale. It's a super uneven particle shape, and it has again been shown to cause damage to cementum, dentine, composite materials, and luting cements, and really is only indicated for supragingival use on sound enamel. So if you've got the Cavitron Jet Fresh powder in your drawer or in your cupboard at work, then that is only for sound enamel. So be cautious around using this in the correct way, and we'll go through the techniques in a little bit. Then we also have a cohort of powders that are bioactive glasses, and this one is calcium sodium phosphosilicate, better known as silk powder, and this is the type of powder that you'll find in that aquacut machine that we were talking about before. So the one that is also used for prepping tissues. One of their powder chambers is designed for silk powder, which is this amazing bioactive glass. It is actually quite hard on the Mohs hardness scale. It's quite hard at 6. So if you remember, dentine is around 4. But there are some studies that show that it can reduce sensitivity because it can adhere to dentine tubules. Now, it is also still contraindicated on restorative materials, composites, GICs, but the producer of silk says that it can be used on dentine. Now, with such a hardness scale and with such large microns, I'm cautious as a clinician. I feel uncomfortable, but there have been quite a few patients that have reported reduced sensitivity. So if you've got super sensitive patients, it may be worth a shot. And then we come to calcium carbonate. Calcium carbonate is the powder that we have used in our NSK machines for many, many years. And it is really great because the shape of the particle is spherical. And I'm going to show you a electron microscope image of that spherical shape later on. It's nice that it's spherical because it sort of rolls off the tissue surface, and so it can cause less damage. It's on the Mohs hardness scale, it's around a 3, and it's quite small in comparison to the other powders we've looked at with a 54 micron size. However, it's still harder than dentine, and it's still shown to cause damage on restorative materials. So again, this powder, Flash Pearl, which is the calcium carbonate powder we use for NSK, is indicated for supragingival use only. Here's that scanning electron microscope image of the difference between calcium carbonate on the left of your screen there. Sorry, you know, in dentistry, we just don't know our left and right, do we, anymore? We're done. So you've got your lovely spherical shaped calcium carbonate particles on the left, and then your sodium bicarbonate irregular shaped salt on the right hand side of your screen there. So just really interesting to see the difference and why it is such a variance in particle sizes when you're using something like aluminium trihydroxide or sodium bicarbonate, and you can see why machines might struggle and clog a little bit more if there's lots of large particles when they're not used to it. So that's our supragingival inorganic powders done. Now I want to talk a little bit about the organic powders that are on offer on the market at the moment. You may have heard of erythritol. Erythritol is has been developed into a plus powder by EMS or electromedical systems with the addition of chlorhexidine. So this is a sugar alcohol. That means it's an organic powder. And they've developed it, EMS has developed it into the Airflow Plus Profi powder by adding chlorhexidine as a stabilizer. And they are using that for both supra and subgingival use. So you will find that in EMS master machines, you can use this powder both for supragingival and subgingival. And I think it's apparently a really pleasant taste. And what's really nice as well is that it's only 14 microns. Now, you remember the powders we were talking about earlier on were 54 smallest. That was the calcium carbonate, right up to 350 something for the aluminium trihydroxide. So 14 microns in comparison is absolutely tiny. And what's lovely about erythritol and also glycine, which I'm going to show you next, is that these powders actually dissolve. Tagatose as well is another organic powder which is only 15 microns. Oh, and look, my number's been missed off on here. It's got a Mohs hardness of 3. So again, really, really low on the scale, but not the lowest. And it's also a sugar alcohol. So these powders, when they are really small micron, when you've got small micron organic powders, these ones you can use on your restorations. You can use them subgingivally, so we're talking actually into a pocket, but you can also use them on dentine as well. And tagatose has been said to be a safe alternative to the gold standard powder, which is glycine. Now, the reason I say gold standard is just because the majority of studies that we've got available to us at the moment are around glycine, and glycine is an amino acid. So slightly different to the sugar alcohols that we've seen before, the tagatose and the erythritol. Glycine is actually an amino acid, and this amino acid is something we produce as human beings ourselves. It's the type of amino acid that turns into proteins. So you are already 90% protein. It's highly water soluble, so you'll notice in comparison to using a supragingival inorganic powder, this powder will dissolve within water. It's a little bit of a larger micron for the glycine powder that NSK produces, but it's really low on the Mohs hardness scale. It's a 2, so very similar to dentine, and again indicated for both supra and subgingival use. Now, I use this powder the majority of the time in my clinic. This is the one, glycine is the one that we use for biofilm removal, biofilm management, also mild staining. I'll show you a video of that in a bit. But NSK have actually also developed a larger format glycine powder. So just to confuse us all even more, first you had the inorganic indissolvable powders that were for supragingival use. Then we've just spoken about organic dissolvable powders for subgingival and supragingival use. Now we've got a bit of a hybrid option. So 65 micron glycine powder is a supragingival use powder. because of its large format size. So it's 65 microns, it's big. But because it's soft and it dissolves, this powder is, although it's indicated for supragingival only, it's more comfortable for your patients. So it's nice tasting, sweet tasting. It's nice and comfortable for your patients to use. And it will also remove the stains from your patient's teeth. In addition to that, the reason that I've switched now almost completely from using inorganic powders, the calcium carbonate that I had used before, is that this dissolving capability of glycine means that none of my suction, my filters get clogged, and it makes it for a much easier, quicker cleanup for my nurses at the end of the day. And I think that anything we can do, right? Anything we can do. Now, I've been talking about the micron size, and size really matters because you need to use the correct size particle powders for the equipment that you've got. So always check with your manufacturer on what powder have they developed the equipment for. If you're putting aluminium trihydroxide, which is up to 300 microns, into the tiny lumen that has been developed for calcium carbonate, which is 55 microns, then obviously you may find you get some clogging and some issues with powder delivery. So always check with your manufacturer on what powder you should buy. And then in addition to that, every manufacturer's air and water and powder combine outside of the tip. And obviously if we combine the air and powder and water on the inside of the tip, it's very likely to clog up. So it actually, you have the air coming through the central tube with the powder in it, and then the water comes through the gap around the outside. And that means that there is an optimal point where these air, water, and powder combine outside of the tip. At that optimal point, that is where you're going to get your best possible air polish clean. Okay, so we will talk about our techniques in a bit, but be aware that each manufacturer changes where that optimal point of contact is. So there are obviously a number of different structures we need to think about in the oral environment, and they all have different resistance to wear. So the powder you choose not only does it have to match your equipment, but it also has to match the situation that you're presenting with. So we need to have a powder that's most effective, but also most minimally invasive as it possibly can be. So I want to show you the difference between the organic small particle water-soluble glycine on the left-hand side of your screen there, with the inorganic large particle size calcium carbonate powder that's on the right-hand side of your screen. And what you can see is that organic powder, it's floating in the air. It's almost kind of floating away, whereas the inorganic larger particle powder, it drops to the bottom of the screen there. So you can really see that there's a huge difference. You can tell when you're looking at powders, if they're gritty to your hands, they're probably a large inorganic powder. Okay, so the nice way to remember it is that small particle organic powders can be used subgingivally. Large format particle powders have to be used supragingivally. Okay, are you with me? And to make it even more clear, here's a little infographic for you. So if you're talking about sound enamel, then you can use anything inorganic or organic. But if you're using powder on prosthesis, on root surfaces, on ortho brackets, on implants, into pockets, then you are going to be needing to use organic powders, okay, like erythritol or glycine. And then what about that technique as well, right? So, okay, Kat, we won't use it under the gum, you said it enough. But if you're trying to remove stains come in all places on the teeth. They're often around the neck of the tooth. So what can you do to keep your inorganic powders away? Well, the technique as shown here is to be 45-degree angle away from gingival margin. So you can see I'm angling this tip up into the suction, the wide bore high volume suction. I'm going to start that video again. Let's watch it again. So we're angling 45 degrees up, and you can see I'm just working around the gingival margins. I actually quite like to move in small circles if it's a lot of stain, but in this case it wasn't. So angling 45 degrees around the gingival margin, then up the tooth until you've removed that staining. And this is a very typical case that you might get in, and you can just see with that high volume suction, there's really very little mess, if any. So you're not looking at tons of powder flying everywhere as well. Okay, that's not the idea. And then with the inorganic powder technique, obviously you want to keep your tip at that optimal distance away from the tooth. Now, if you've got really, really strong staining, then you might need to be around 3 to 5 millimeters from the tooth. But if you've got light staining, you can actually move further away, and that means you're going to get more surface area when you're cleaning that sound enamel. Now, subgingival powders, as I say, the organic dissolvable subgingival powders can be used around the gingival margin. They can be used to the gingival margin, so they can actually get around about 4 millimeters below into the pockets, sulcus as well. But they can be used for light stain removal as well. Now, though this doesn't look like light stain removal, it was quite a soft stain, and this is the glycine powder at work, just really getting in there and removing those little stains. I feel like I could watch videos like this all day. Anyone else? Now, because it is a small particle powder, you noticed it was 14 microns, 23 microns, around that size for these organic powders. Then what you do need to make sure you're doing is using the right equipment. If you are putting this organic powder into a machine that is designed for larger particle powders, then you will just lose all the powder out the nozzle, and it'll be a huge waste, and it won't be effective because it won't have the power behind it. It needs to have that small lumen to allow it to have the power. Okay, so you try not to just buy the powder, you do need to buy the equipment as well. And then obviously there's two ways of using this subgingival powder. The first one is just removal of extensive plaque or light to moderate staining. So you can use that nozzle at any angle, moving in a circular motion is really effective. And also that same distance, sort of 3 to 5 millimeters from the tooth surface, you might have seen I was slightly closer to get that stain off. But then also you can maintain pockets, so pockets that are non-bleeding, that are not perio affected pockets. There might be your maintenance pockets of 4 millimeters. You can either use nozzles, so both NSK and EMS have nozzles that will go on the end of their subgingival powder hand pieces, or you can use it without a nozzle. Personally, I'm a big fan of using it without the nozzle, and they will be effective up to 4 millimeters without 5 millimeters width. If you want to increase that depth and that ability to get a bit deeper, then you can use those nozzles as well. And then this is a nice infographic about that technique. If you do put the nozzle on, you are able to go subgingivally down to around the 5 millimeter mark. You would work in small circles. And what's nice about having the nozzle is it actually directs the powder laterally and the water subgingivally. So you get a lavage, but you also get the powder onto the root surface in a lateral motion rather than pushing it straight down to the sulcus, which can be, a little bit of a concern when it comes to surgical emphysema, which we will talk about a little bit later on. Obviously, manufacturer's instructions do vary, so please, if you're not using NSK, which is the infographic picture I've got in front of you there, then please go and speak to your manufacturer and ask for their advice. Now, what powder when? Just as a recap, first think about what equipment do you have. So what is in your surgery? What is available to you at the moment? So the first thing is what equipment, because you then will be limited to what powders have been designed for that equipment. The next thing to consider, obviously, is putting our patients first. So what is the patient's situation? Are you looking to clean supragingival or subgingivally? Do they have any aesthetic restorations that could be affected by the powders we choose? Are you cleaning implants, brackets, or attachments? Also, do they have any contraindications on their medical history? And then you can choose which powder from having narrowed it down. So like I say, any of these powders, depending on what your patient's situation is. So we're on to our clinical indications. How many times have we seen little old ladies with skinny roots because they've been root planed for years and years? Well, if you've got really well maintained perio patients, you can maintain them so much more gently now with your organic air polishing powders. You don't need to be root planing these patients. Also, thanks to Siobhan for this brilliant video. I actually think I should just play this to relax on a Sunday. Love a bit of disclosing solution before air polishing it. I did exactly this on some ortho brackets today. Again, why am I not taking videos? Anyway, and it's just brilliant for cleaning around orthodontic brackets. I would be using subgingival organic glycine powder for this, and that will really help your patients to remove the biofilm. Of course, we are really lucky to have had our S3 guidance on implant management and management of implant peri-implant diseases, and it has said, I believe it's something like page 21 or 22 of that document, if anyone wants it. It does say that air polishing is indicated as a single mode of treatment for peri-implantitis and also for maintenance of implants. So go and have a read of that one. We do have some studies that show us the effect on the titanium of implants. There's this brilliant study that shows the difference between tagatose, which is that sugar alcohol, glycine, and the control before and after having used air polishing devices. And basically they have said that there is an insignificant changes to the surface topography of the implant. So basically you can use your small micron glycine or tagatose powders effectively without changing the surface topography of your implants. And there are, if you want any more studies around polishing on implants, please feel free to have a look at the 2 studies that I've put in front of you here. A really old one that you know we often refer to back in 1998. My goodness, I was 12. It shows that 60 seconds of treatment showed 100% biofilm removal with little to no effect on implant surface. Now, I know that some people are going to say they weren't even born. I don't want to hear it. And then clinical indications, again, we actually we can use our air polishing devices to gently clean dentures or other prosthesis. So this is a brilliant video that Lauren Long has sent us and allowed us to use, of her cleaning the implant prosthesis that is has been removed by her implant dentist so that she can get it cleaned. And it's such a great idea, because this is the sort of thing that you can get your nurse involved. You can suction with it, or you can pop it into a plastic bag and you remove the biofilm, so that once you've cleaned your patient's teeth, they're not putting a prosthesis back in their mouth that is covered in biofilm. Wouldn't that be mean? And then obviously fissure sealants, which we really should be remembering is part of everyone of a hygienist's scope of practice and a therapist's scope of practice. And when you prepare a tooth with air polishing, you can actually see a significant increase in the depth of penetration of sealant resin, around about 70%. And so air polishing has been recommended as a standard cleaning method before fissure sealing, especially if, you know, those fissures are deep, they all have biofilm in there, they have staining in there, you know, they have all that sticky yellow plaque in there. So we know that if you use your air polishing machine prior to etching, then it will elevate the bond strength. We also know that etching teeth does not remove biofilm. So you know, when you use etch on an enamel surface, yes, you might be creating tags in the enamel, but it doesn't actually lift or remove biofilm. So you do need to do something prior to doing your etch. We talked a little bit earlier on about contraindications and some considerations to have around your patients and using these machines on them. Obviously, we mentioned sodium restricted diets. there is a contraindication for pregnant or breastfeeding women, only because obviously it would be unethical to do studies to say that it was safe. We would avoid using air polishing in patients with respiratory conditions such as asthma, COPD, untreated bronchiolitis, and the standard communicable infections such as cold sores. So there are some things that you would need to go back to your manufacturer device recommendations as well, and just double check what they say in their literature around the machines that you're using. Now, after you've done your air polishing, you've removed that salivary pellicle from the patient's teeth. So it's really nice to recommend to your patients no tea coffees or things that stain their teeth like smoking. I always like to apply some fluoride straight after. So I use Biosmoto by Curacept. That's a mouthful, but it's a really nice clear fluoride gel that patients love. It's got a lovely flavor, but you can use anything. You can even use Voco from Ivoclar. Theirs is great because it's clear again, or even just one of those little toothpaste samples on a cotton wool bud or cotton wool roll is really nice for patients as well. And then that salivary pellicle will reform within the hour. So no tea, coffee, no smoking for an hour while that pellicle is reforming. And then obviously we need to be cautious about our subgingival use. We need to be careful not to disturb the junctional epithelia that we have at the base of pockets, especially if we've done any periodontal therapy. So if you've got really inflamed, swollen pockets, if there's loads of bleeding from a pocket, if there's suppuration, or you've just done some periodontal therapy, then blasting a load of air and powder down there is probably not going to help our patients. And then there's the obvious perio endo involved teeth. So if that tooth has got a J-shaped lesion around the base of the root there, if you know it's perio endo, if it's you're doing perio treatment and it's going for endo treatment, then this would be contraindicated for you to use. And the reason why a lot of these things are contraindicated is for this very rare complication. It's super rare, but we must talk about it. Surgical emphysema. So a surgical emphysema is gas or air being trapped subcutaneously. What the patient feels is this swelling or crackling pain and tenderness instantly, and that will feel like it's creeping up the face. It will require antibiotics, and that patient does need to be observed for 30 to 60 minutes, and then called back in. Most symptoms should go after 48 hours. There are studies that say that it's super, super rare, but these studies are quite old now. We haven't got anything new. So the studies are more than 20 years old, sadly. Haven't got anything new to say how many surgical emphysemas have been caused by air polishing devices, but I do know that, surgical procedures with fast handpieces, air-driven fast handpieces, do involve the same risk, and we just need to be really cautious that we don't cause this kind of a problem. So no subgingival treatment in patients with inflammation, swelling, suppuration, perioendo lesions, and just be really, really careful around gum margins. So it's really about having a bit of a patient-centered approach. Not every patient will be suitable for air polishing, and that's I think a really key thing to take away from this evening, is that you can't just blanket advertise for every patient to come along and have air polishing, because it's not suitable for everybody. So check their medical suitability and check their clinical suitability. Make sure you have the right powder for the right situation for the right patient. Then obviously it's all very well removing biofilm, but we actually want to educate our patients on making sure they keep it away. The biofilm will be back within around 12 hours. So it may be not to the same extent, but it will be growing again. So it's all about education, behavior change on prevention and maintenance. Obviously choosing the system that's suitable for the patient's situation, and then making sure that you give them those post-operative instructions, place fluoride or some calcium amorphous phosphate in order to remineralize and protect them when they don't have their salivary pellicle. I also would like to talk about it being a clinician-centered approach. It's an incredibly safe technique for us to be performing on our patients. Obviously, I would really highly recommend having a nurse. So having somebody holding the wide bore suction, having that high volume suction is crucial with air polishing. I also have a saliva ejector at the back of the patient's mouth. My nurses are amazing, super good at making sure they're in the right place at the right time. This is a clinician centered approach because it's just helping us to be super effective, enjoy our jobs, and not have to continually have that repetitive motion that we have to have with other cleaning techniques. Also, it might be that your clinician, your clinic decides that you want to charge for this additional treatment. And so it could help improve your financial situation if you are doing this. And it is a fantastic additional argument for why you will need nursing assistants, which everyone should be having at the moment. As a close, obviously, one of the big things that we hear is people struggling with clogging on their air polishing machines. So please follow your manufacturer's protocols when it comes to maintenance. So the NSK ProfiMate does come with a maintenance protocol. You're seeing me, the video, I'm going to put that video on again. You're seeing me just showing off this maintenance product. There is a little nozzle here, which is an air nozzle that goes onto the fast handpiece after every use, and it blows air through every part so that you are clearing away any additional powder that could be caught in any areas before that is sterilized. So there's plenty of help on the NSK website for NSK products, but also every manufacturer should have a manufacturing protocol for maintenance that they should be able to share with you. And I can tell you it really matters, because otherwise you will get images like this one that I received this morning about the consumable parts that we do need to know about on our air polishing devices that need changing regularly. So these are the O-rings, and I've had the engineer has very helpfully pointed out to me the areas where the O-rings were a little bit worn on our ProfiMate air polisher, and the reason why it needed to go in for repair, which it absolutely didn't need to go in for repair if we had just changed the O-rings. So I'm holding my hands up, guilty as charged here. Probably should have checked that before sending it off, but you can just see these tiny little abrasions on the O-rings where they've been vibrating backwards and forwards in the machine. And these are really, really miniature. They're, you know, smaller than a biro. Those little abrasions are the reason why you often get issues with your machine losing power or clogging. So always check your consumable parts as well. I hope that's been helpful. If you'd like to know more about NSK powder therapy, then this QR code will guide you, take you to the guide for NSK. I've spoken about manufacturer's guidance so much, I thought I'd better give you it. But thank you so much, everybody, for taking the time to listen to me this evening. I hope you found that informative and helpful. And if anyone's got any questions, I'm more than happy to answer them now.
Yes, we do. Thank you very much, Kat. So how do you get trained in using air polisher? I wasn't taught it at uni, graduated in 2018. I understand how to use it in theory, but it feels a bit scary to use it on a paying patient without trying it first.
Yeah, I mean, this is the thing, the GDC scope of practice says you should be competent, trained and competent in what you're doing. And so you can come and access training with myself at NSK. NSK provides training programs all over at universities and also at the NSK head office. We also do training days we did one at the OHC where you could come along and be trained there. So please reach out, and we can, on the NSK website, we have advertised a number of different sessions. Lauren and I are doing a full day of air polishing training and other things as well, and that's coming up soon. So please keep your eyes peeled for dates.
What is that date, Kat? Is that April?
Well, we had a date in March. The venue is currently to be confirmed, so we're
Okay.
coming back to it. But yes, Lauren and I need to put our heads together and find a venue now.
Yeah, okay. What do you suggest if the clinician or the nurse have asthma? Is it contraindicated for patients with asthma? Thanks.
Yeah, I mean, this is the thing. I have asthma, actually. I especially during winter and when I'm around animals, I have asthma. I don't find it a problem for myself. I think what you'll find is obviously the air polish machine isn't in my mouth. It's quite a long way away from me. And if you're using it correctly with the powder turned down, the water turned up, you shouldn't be getting any plumes of powder in the air at all. So it shouldn't really affect your asthma. Now, the difference being that when I worked with that Cavo machine all those years ago, obviously it was very old and one of the early models, but there was powder going everywhere. If you've got powder going everywhere with your machine, there is a problem with technique or the machine. So it's either your nurse's technique when it comes to suctioning, your technique when it comes to where you're putting the powder, or the machine is allowing too much powder through. If it's enough powder that it does affect your asthma, I would say check those things first. But obviously don't put yourself in any risk. If you feel like it's affecting you, then maybe it's not an ideal treatment modality for you to use. And don't feel guilty about that. It's okay. There are plenty of other ways that you can clean teeth or maintain your patient's periodontal health. Nobody's saying that air polishing is better than ultrasonic scaling and prophy paste as well.
Somebody's saying actually ignore the question because I think you answered this now, but using subgingivally, is it okay in both bleeding and non-bleeding pockets?
Yeah, I avoid bleeding. If it's just if there's a little bit of bleeding, sort of like marginal gingival bleeding, and it's a small amount, then that's really, to me that's okay. But if you've got bleeding from the base of a pocket, you know what I'm talking about, real blood, there's absolutely no way I'd be going subgingivally then.
Yeah, and again, just to stress that this is a maintenance supportive program. It's not for therapy.
Yeah.
Do you air polish and then ultrasonic afterwards for calculus?
I love this question. I really need to change these slides and put that in. I actually change depending on my patient. I never ever want to do a one size fits all protocol when it comes to what I do for my patients. So today I had that very first patient in, who was in for a hygiene appointment, and she had chromogenic staining everywhere. It was to the point where my nurse and I were sort of like getting excited because we do. And she actually just had loads of stain and very little calculus and very little else going on. And so we went straight into air polishing, picked up the ultrasonics afterwards and used the piezo just for some refinement here and there. But the air polishing was the right tool at that time for the situation. Whereas later on in the day, I had a patient who actually had quite a buildup of calculus, but he didn't really have an awful lot of anything else going on. So we did the calculus removal with Pizon, and then here and there was just a little bit of staining, like in the grooves and pits of palatal, of the palatals, and that's just so nice just to be able to get in there at the end with the air polisher. So it's never one size fits all. I really think it would be crazy to air polish that patient first, because I'd be spending ages and then I'd still have to go back. Whereas having used the ultrasonic first, there was just little pieces that I could pick out and enjoy cleaning.
Yes. Do you always disclose prior to use?
No, I don't. I've got some pretty high flyer patients in my clinic in Canary Wharf, and some of them don't want disclosing because they're off to work and they've got meetings, the last thing they want is a little blue patch on the side of their tongue, um, or on their lip or whatever. And that's absolutely fine. I also don't disclose everyone because to me, sometimes I feel like I'm not really there to shame someone into the fact that there's plaque on their teeth. You know, I can see it, I can tell them where it is. My patients trust me. Some of them really need to see it, and we love disclosing them. And I disclosed the orthodontic patient that I had this afternoon for that reason, and it goes really well. But some patients, you know, if they're maintenance patients and I've seen them regularly and I actually think they're doing really well, I don't think it's necessary to do that.
Okay. Hi, are any of the NSK powders able to be used on asthmatic patients if they are stable? Thank you.
I think you need to really ascertain about stability of your asthmatic patients. I mean, I have a patient who had, you know, salbutamol inhaler as on his medical history, and I said to him, "When did you last use your salbutamol inhaler?" And he said, 12 years ago. And that's not an asthmatic patient anymore. That's a patient with an out-of-date salbutamol inhaler, right? So I think, you know, obviously proceed with caution, but you really have to decide, are they actually asthmatic or not? You know, that patient, he's not had any asthmatic diagnosis for that long. He's not what I would consider an asthmatic patient, but no, the real answer is that no. In the NSK manufacturer's instructions, they do specifically say not for use on asthmatic patients.
I do struggle using air polish on palatal surfaces, especially on the right-hand side. Any particular tips on it?
Oh, completely agree with you. It's really tricky sometimes
It
up
is.
there. It is. And that patient with the chromogenic staining this morning, it was all on the right palatal. And I think that's because the last time it was cleaned, whoever cleaned it struggled there as well. Actually, what I do is I tend to get them to turn onto that ear, so onto the right ear, and put their chin right up. So kind of like that kind of movement. And then I come round to 8 o'clock. And my nurse will be suctioning from the other side. So I'll sit almost facing my patient and clean that way. And I get a lot of enjoyment out of seeing it in that way.
Yeah, we could do maybe some little videos of that to show.
Yeah,
That's
that's a
probably
great.
something we should do. Keep that in mind. I hope that helps. I have been using NSK Various for 3 years after using a Cavitron since qualifying in 87. It has completely transformed my perio treatment. Fabulous patient outcomes. I love it.
Oh,
Yeah,
that's so good to hear.
the tips are lovely, and for a minimum invasive approach, they are absolutely fantastic. It is always contraindicated with asthma. Is it always indicated for asthma for supragingival, even if it's well controlled? It's back to the asthma again.
Yeah, I think it's the same answer. You know, you really have to have that conversation with your patient. If they asthma is just such a broad subject. I actually remember my mum's a nurse and she did a master's on asthma and COPD, and it's such a broad subject that diagnosis of asthma means different things to many different patients. So you need to delve into it. But ultimately, you will put yourself at risk if you use a powder on an asthmatic patient who you know it is contraindicated on. If there's a concern, because your indemnity will say, well, it said it will, it's contraindicated in asthmatics. You knew the patient was asthmatic, therefore you shouldn't use it. And the point is, you can get just as good results, perhaps with a bit more time, with ultrasonic and air polishing.
How do you deal with grumpy patients who come in expecting airflow? Airflow is actually a term coined by EMS. So air polishing, but they aren't suitable for it due to medical contraindications, etc.
You just have to say, listen, I'm so sorry, but it's just not indicated. You know, because of your medical history, it's not something that I can do. But I'm really good at this, and I'm gonna get those stains off for you otherwise. You just see. And then you show
Yeah.
them your magic skills with your Pison and your excellent, you know, piezo tips and polishing, because we can all do it, you know.
How do you alter the flow of powder?
So it depends on the machine you've got. You know, sadly, on some of the handheld machines, you can't. On the Perio handheld for NSK, you can alter the flow. And then obviously on the standalone machines, the NSK Varios Combi Pro VCP, there's this like beautiful touch screen that you can reduce the powder, increase the water, and have really good control over it. So it really depends on the machine you're using. But again, pop back to your manufacturer and have a look and ask them.
Cleaning implants, do you suggest an air polisher combined with ultrasonic or only an air polisher?
So the S3 guidance that came out does say that it's only indicated as a single mode of use to clean. So it's basically saying choose one, choose ultrasonic or choose air polish. It's tricky, isn't it? Because we all know that we whip round with both. But you know, realistically, if you've got calculus there, you're going to need an ultrasonic. If you've only got biofilm, we know from long ago that studies have suggested that 60 seconds of air polishing is going to remove 100% of biofilm.
I think it's a little bit more in depth, that question, and thanks for asking it. And I'd really recommend, if you haven't been on an implant course, Catherine Mayo and Jenny Walker do a course up in Iceland. They do a day in Stevenage. I'm sure they'll do some more next year. I think there's a waiting list for ICE, but maybe we can get the details out to you on that. But I think it'd be really important to go on that course to understand that, because you can use like an ultrasonic tip when there's peri-implantitis, but I'll say it's a little bit more complicated. So I would suggest that. What powder and water levels would you use on an NSK machine, please?
Depending on the situation, I always start with the powder low and the water high. And then we're going to increase our powder until it's working effectively for the situation of the patient. Always like to have water high for air polishing and water low for ultrasonic. But yeah, water high for air polishing. Start with the powder on the lowest and then just slowly increase it until you're at the point where you feel like it's working really well for you. You know, it's one of those things, it really depends on the type of staining. If your patient has beetle nut staining, then you're probably going to have the powder really high.
Can we use it on loose mobile teeth?
Oh, stick your finger on it. Listen, it's the same as the ultrasonic. If you use it, then you might lose it. That very loose mobile tooth, you have to be super cautious. You're going to put the wide bore suction next to it. If it's going to be sucked away by a wide bore suction, I'd probably say perhaps no. But if you think it's going to stay in and you can keep it in, stick your finger on it and go for it and get rid of that biofilm.
Again, it's what's been presented to you, really, because if a tooth is mobile or loose and the tissues are not attached fully, you are kind of at risk of air going in under the gingiva. So again, with something like that, I would just err on the side of caution.
Yeah, you wouldn't go subgingivally, certainly, but I do have one patient who has followed me from practice to practice with a grade 2 mobile molar with, you can see through and through furcations, and all we do is subgingival glycine air polish through those roots every 3 months, and there it is. It's been there for years.
So would you say hands-on experience is essential before performing on a patient?
I think absolutely it's really worth having hands-on experience, but that doesn't mean to say that you have to go on a course. You could have a clinician who does know how to use air polish and is confident in show you, and you could practice on a nurse, a friend, a colleague, a family member, and have a feel for it. You can practice on models as well. But you know, there are training options out there as well. So I wouldn't say that you absolutely have to have a official or structured training on it, but it would be really beneficial to have somebody really knowledgeable around the product to show you exactly how to use it and what it's indicated for.
Yeah, I think it's good to get hands-on training before you do this, even just so you feel more confident yourself, really, in the surgery. Could air polishers be more environmentally friendly, sustainable than traditional polishing using Profi ultrasonic only?
Wow, that's an interesting question. What do you think, Siobhan?
Friendly. Well, I guess so, because you're not having to use rubber cups and brushes, and they're all disposable.
So the only thing I would say though is you would have to really look, if you really wanted to think about it, you'd have to look into the manufacturing of powders versus the waste and manufacturing of Profi cups and brushes, and then have a look at the carbon emissions that are produced in both. Tricky one to answer, isn't it?
Yeah, you would have to look at the companies, yeah, that where the supplies come from. There's a whole chain there, Zabe. It's very interesting. Maybe a little bit of research for you. Tracy Dooley would like that one, I would say.
I was just thinking I'll send her that
Yeah.
question to find out for us.
If air polish is added as an extra money on top of this S&P, when would you polish with Profi, before or after the air polish?
Oh, I don't use Profi. If they're having air polish, that's what they're having. I don't know. Well, would you use Profi as well as air polish, Siobhan?
So this is the thing. I think it's a business at the end of the day, and patients absolutely love having a polish,
Mm-hmm.
despite having the air polishing. So sometimes I will just put like a Kinbee 5, 1450 parts per million onto the little rubber cup, and I'll do like a polish round with that. So I'm applying the toothpaste after the air polishing. They're really happy with the polishing effect, but it's not doing any, so it's a minimally invasive approach again, which we keep coming back to. That's my way around it. Otherwise, you're kind of double jobbing, really, aren't you? You know?
Yeah, I mean it's an interesting one because it's certainly that wouldn't help with your environmentally friendliness.
No, no.
But
Do you?
you know, I think some patients do really love a polish.
They
But
do.
I think after they've had air polishing, they sort of really feel that they've had a polish, whereas before they just have a gritty mouth. So, so I tend to
Well,
just,
depending on the paste that you
that's
use, you
depends
can.
on the person.
I use really nice ones, but so do you charge them extra fee for cleaning their dentures?
I don't. I think it's a nice thing to do, and it's nice to be nice. So we don't.
Do you PMPR first or after air polishing? I think we kind of
Again,
answered that.
totally different. PMPR is actually professional mechanical plaque removal, so air polishing is part of PMPR. Just if we're being correct about our terminology, but yeah, it depends on the patient situation.
From what age can airflow be used?
I've used it on young children. You know, I've used it on my own young children. So long as you've got compliance, you're confident, and I would only be using subgingival powders on a low
Mm.
setting for young children because you have to be really cautious around soft tissues. These supergingival large format inorganic powders will cut soft tissues if you touch them with it. So I would not be using that on a child.
What is your favorite piezo tip for stain removal, please?
Oh, I love a G5 for stain removal for the NSK tip selection. G5 is sort of a half elliptical shape, so it's got two working edges. It's short and kind of stubby, but it's also got a nice point on it. Doesn't cause any gingival trauma, but it's got a wide enough working edge to really sweep away stains. So I love a G5. It's really sad that that's made me happy having that question.
What was the name of the Cureprox gel you were applying? I use tooth mousse or Biomin, but would prefer something clear.
Yeah, Malto. It's really hard to pronounce. Let me just pop it in the chat.
Okay. While you're doing that, I'll just. Hi,
Biosmol.
do you advise post-op sensitivity to patients for super use on sound enamel? Okay, so this is what we're putting in now. Is it more likely Is this more likely than use of standard pro-free paste?
Say that again.
No, I don't know. Do you advise post-op sensitivity to patients for supra use on sound enamel?
Oh, do you
Is this more likely?
you tell patients that there might be post-op sensitivity? I
Maybe.
don't, because I haven't had anyone come back with sensitivity. But if you've got patients and you're using this on root surfaces or using the incorrect powder on a root surface, you might get some sensitivity. So you shouldn't, if you're following protocol and using powders in the right places, there should not be sensitivity. If you're using it on sound enamel, or if you're using a soft organic small format powder on dentine, there should not be sensitivity.
How do you sell this to patients?
Oh, I say exactly what I think. So I think that it would be really wonderful to maybe have some air polishing on your teeth today, because there's an awful lot of biofilm and the air polish will really help us to remove it. Or because you've got a lot of staining, we already showed you on your photographs and scans, and this will help me remove it in a little bit more of an effective, quicker way. Would you like to go ahead? And they often say, I'd love that, Kat. Thank you very much.
Yes, this webinar is, you can watch this back on demand, will be up in about 7 to 10 days. There will be, look out for your email for evaluations that will come out, fill those in, and the certificates will be sent out to you. Are there any known long-term effects for clinicians using these powders?
No, I haven't seen any studies on that yet, but these powders have been around for years and years. So there have been some studies. In fact, I might have had a slide with it up there. There's a study on the top of this slide that looks at the safety and efficacy of treatment with air abrasion technology, and that does mention the safety for clinicians as well. So if you want to look at research, this is the only research paper I could find around the safety for clinicians.
Thank you, Kat. Thank you, everybody. Lots of questions there. I think if you've any more questions, please reach out to us. We're more than happy to answer any questions that you have. As I said, there will be an evaluation that will go out, and we'll be just fill that in and your certificate will be sent out to you. Paula, do you have written consent for airflow in your practice?
No, I don't. Oh, Siobhan, did we have a discount code we could give to everyone listening?
Yeah, I put it back in again. So can everybody see that? I put the discount code in, WCE 1224, and it's valid until the 22nd of the 12th. That's the NSK web shop, or you can reach out to any of the reps about that as well. So I get quite a few emails about that after the webinars. So that's why we're starting to put it into the chat so you can write it down. Thanks for answering my questions.
Oh, lovely. It's so nice to have everyone. I can't believe we had so many people online this evening. It was so lovely. Thank you, everyone, for all your wonderful questions. You know what this does, Siobhan? Every time I do this webinar, we have hundreds of people joining us every time. It tells me how much this profession cares about their patients, and it just makes me so happy.
But also, I think this is kind of a difficult topic for us because we don't have S3 guidelines, and we want to keep recapping, don't we? And we want to make sure that we're keeping our knowledge up to date. So as long as you keep turning up, we'll keep putting this webinar on, and Kat's agreed to do it again next year. But please reach out to us if you have any further questions. So have a lovely evening. Please join us next week for the Pechakucha event. We're going to Tanzania in March, aren't we, Kat?
We are. We're going to be without proper bathrooms for a whole week, Siobhan. What are we going to do with ourselves?
Please don't remind me of that part of it.
So we're going to Tanzania because we are going to educate educators in Tanzania about preventative care for the young children and tribal communities within Tanzania. So our goal is to educate 1,200 educators in a week with the NSK Ikigai team. And we're going to be teaching them how to all about oral hygiene, all about oral health, how to use the Miswack, which is super exciting because it's something that's sustainable and they can get again and again. But also we're going to be educating about infant oral mutilation, which is just the most horrific practice that happens still in some places in Tanzania. So we have been invited by Bridge to Aid and by the Tanzanian government to go and do that, but we're raising money to support the cause.
We've got 6 speakers, 6 different topics, a great judging panel. So look out on social media and I'll put some posts out there. Thank you very much, everybody. Thanks again, Kat. Really appreciate it. And have a good evening, everybody.
Thanks, everyone.
Bye now. Bye-bye.